Hi, Darren. Hi, Kimberly. Hi, Melissa.
Hi.
Thanks for joining
Hi.
us.
Good morning, all.
Good morning.
How's everyone doing today? We're at 8:29 Pacific right now, so we'll give folks a couple minutes to join. Thanks for coming on early. We'll get started soon.
Hello, all. Thanks for joining us. We'll get started in a second. Let's let people join.
Good morning. I see Melissa, Stephanie, Brian. Hey guys, welcome. Hey Phil, hey Ella. Jamie Hart is joining. I see Marianne, Dr. Clemente, Faye is on, Seren is on. Good morning, everybody. We will be giving folks just maybe a couple more minutes to join. We're at 8:31 right now. I see 21 participants in, so I'll give folks a second to join. See, Ingrid just joined. Welcome, Ingrid. Welcome, Nora. Welcome, Yael. Hello, hello.
Good morning.
A few more folks joining. Feel free to turn your cameras on if you'd like, if you're in a space where you can, or if you can't, that's okay too. Just putting the invite out there. We'd love to see you if possible. So we are at 8:32. Why don't we go ahead and get started? I see 28 folks have joined so far, so hopefully folks will continue to trickle in, but we can go ahead and get started. So thank you all. Wow, I'm so excited for our first learning session today. I am overjoyed to see so many participants joining and really excited to dive into this learning collaborative with you. We've put a lot of blood, sweat, and tears into putting this together for you. And we hope that this will be an important and collaborative experience for you all. So today's session, we're going to be focusing on using performance measures as a tool for patient-centered contraceptive access. And we'll have two excellent speakers presenting on that topic. Next slide, please. Let's do this. I'm literally so excited. So next slide, please. I'll give you a little rundown of today's agenda. We'll do a couple quick introductions so folks can get to know each other on the call. We'll have Jamie Hart presenting on equity and performance measures, and we'll turn it over to Christine to present on using performance measures in contraceptive care. I'll do a quick community check-in later on today. We'll talk a little bit about QI, next steps, and other happenings in the collaborative. And then we'll have an open space for any questions that you may have, and we'll wrap it up from there. We are on from 8:30 to 10 today, Pacific time. So if at any point you need a bio break, please feel free. You can just write in the chat, BRB, go into the bathroom, and then come right back. And then again, if you have the ability to come on camera, that would be great. We'd love to see your face. And I believe we have folks muted for now, but if at any point you want to come off mute, ask a question, if something comes up, we definitely want to encourage you all. This is a collaborative experience and we want to hear from you all. During presentations, if we can just hold questions until the end, that would be great. But if any technical hiccups come up, we also have our UCSF team identified by our cool UCSF backgrounds. If you have any questions, please feel free to write us in the chat and let us know that you're having any technical or other issues. Next slide, please. So for our goals for today, we're going to create a shared understanding of why using quality measures and contraceptive care is an important practice. We're going to provide some information about the 2 quality measures that we use in the project, the PCCC, the person-centered contraceptive counseling measure, as well as the sync-based ECQM. And we're going to lay a foundation of shared knowledge about patient-centeredness and health equity in contraceptive care. Those will be our overarching goals for our session today. Next slide, please. Again, to orient us in our project goals, we are looking to improve patient-centeredness in contraceptive services in health centers through the use of quality improvement strategies that are informed by performance measures. So again, that PCCC and the sync-based ECQM. Next slide, please. A little bit about us. I know we've had some meetings with you all before, but just to orient us in our mission at the Person-Centered Reproductive Health Program. So here in PCRHP, we aim to advance reproductive autonomy and well-being by conducting research and designing programs that center people's experiences and preferences for sexual reproductive health and healthcare, guided by an attention to the intersecting oppressions and structural injustices that impact people's lives and health. This project is definitely a part of our mission in PCRHP, specifically around structural injustices and oppressions. Next slide, please. And here's us. Here's a slide that shows all the folks from our team. I don't know if our teammates are on and want to just give a quick shout out. We can go in order of the pictures if that works. Christine, you want to say hi?
Hi, thank you so much. I'm Christine Dellendorf, family physician and researcher, and I work at a FQHC. So I'm so happy to get started with all you all and to have you all part of this project. So thank you so much for being here.
Hi, everyone. I'm Danielle Hessler-Jones, health psychologist and professor in family community medicine, and really have appreciated so many partnerships with community health centers over the years, working on practice transformation and person-reported measures, and really looking forward to working with all of you.
I will say a quick hello. Hi, everyone. Lindsay Gibson. I use they or she pronouns, either are fine. I'm a senior project manager here in PCRHP, where I lead the ICC and CHCs. Really excited to see you all today, and I'll pass it over to Becky.
Hi, everyone. I'm Becky Kriz. I am the program director at the Person-Centered Reproductive Health Program. I use she, her pronouns, and I'm a nurse by training, and I focus on contracts and grants and payments.
Hi, everybody. My name is Sonia Goch Avila. I use she, her pronouns. I'm a program coordinator here at PCRHP, and I will pass it over to Erin.
Hey, good morning, everyone. I'm Erin Wingo. I use she, her pronouns. I'm also a senior project manager with PCRHP, supporting a number of projects. In the context of this project, you'll mostly see my name in relation to data. It is such a pleasure to see you all this morning.
Bar Harbor folks, I saw Phil
Sure.
and Ella and Faye, if y'all want to say a quick hello.
Sure. Hi, my name is Phil Hastings. I'm the principal statistician at Bar Harbor. We're supporting the team on the calculation of the measures and data analysis. Faye?
Hi, I'm Faye Dong. I'm a research statistician at Far Harbor. Nice to meet you all again.
Hi, everyone. I'm Ella Puga. I'm a public health scientist at Far Harbor and happy to be here with you this morning.
Thank you so much. Jamie, do you want to say a quick hello?
Sure. I'm Jamie Hart. I'm Executive Director of the Coalition to Expand Contraceptive Access, and I partner with PCRHP on many things and do a lot of work at the national level on performance measures and measurement in general, and on framing and implementing sexual and reproductive health equity.
And we're so delighted to have you working with us on this project, both Bar Harbor and Jamie. Thank you so much, y'all. Next slide, please. And we welcome all of you. So many wonderful faces on the call today. I'm thinking, next slide, please, Sonia. I'm thinking we could take this time to do a little introduction from your end. So if folks are able to come off mute, we sent a few of these questions prior. If you're comfortable sharing your name and pronouns, your job title, for Clinic Champions, who else from your team is on the call today? We'd love to get a sense of who all is here. And then a quick reflection question. So what's something that you've worked on and accomplished with your team at your site that you're proud of? It can be anything from like a huge overhaul change to we tested a new way to collect our PCCCs, and we're really proud of that. So if anyone is interested in going first, you can go ahead and come off mute. And who's going to be our brave first person today?
Hey, this is Jody Baby from Hometown Health Center. We're based in Schenectady, New York. Love all of you guys. You're super upbeat and I love the energy. So I just want to point that out there. I am the application team lead here over at Hometown. So I do everything from cybersecurity to EHR management. We have on our team Dr. Kimberly Clemente. She's one of our OB-based providers, and she's incredible. We also have Lori Mecca. She is one of our QI managers. One thing that we're super proud of is we took the PCCC survey and implemented it on an iPad. So we just had some iPads rolling around, worked with my IT director to get it up and rolling. So it was really useful after the patient had their survey to go ahead and just fill it out. Dr. Clemente was able to grab a couple of the other OB providers and get them on with using that iPad. So that really was a very helpful aid in boosting up our numbers for those surveys. So nice to meet everybody.
That's awesome. Thank you so much, Jody. That sounds like a really interesting strategy you guys have taken. Would love to hear more about that. Folks on the call, anyone else want to go next after a rousing introduction from Hometown? Hey,
I can
Stephanie.
go. I'm
Yeah.
Stephanie White. I'm a family physician and the Associate Dean for Clinical Education for our medical school. So I oversee all of the 3rd and 4th year of the medical school. Pronouns she, her, and also on the call is Brian Lovelace, my dear friend and our chief medical officer, who's a family doctor and an OMM NMM specialist. And something we're proud of, in 2021, with basically no experience, we created a mass vaccine clinic on campus for an underserved community and figured out how to do it, and went from our first day of vaccinating 60 people to our best day of vaccinating 1,400 people. And over a few months vaccinated 33,000 people out of just sheer grit. So I'm really proud of that.
Incredible. Thank you so much for sharing. Folks, anyone else want to go next?
I can go next. I'm Heather Mason with Public Health Seattle King County. I use she, her pronouns. I am the family planning program manager. I just want to give kudos, Stephanie. That's coming from a public health perspective. That's phenomenal. Amazing work. Let's see. What else am I supposed to speak to? I'm the only one on the call today, but I do want to speak to a quality improvement work we've been doing to make our centers more welcoming for LGBTQIA folks. We've been expanding our services. We are doing a lot more with PrEP and monkeypox screening or testing now. and syphilis testing. So we've changed a lot and expanded a lot of our STI and HIV work, which has been really important. So that is me.
Thanks
Nice
so
to see
much.
you.
Heather. And just a little ping, Sonia put the questions in the chat. Again, name, pronouns, job title, who else from your team is on today, and then something that you've accomplished that you're proud of at your site.
Yes, I can go. Excuse me. I'm Nora Sandy. My pronouns are she, her. I am the Vice President of Health Centers at National University of Natural Medicine. With us on the call today is Dr. Malia Ermack. Dr. Ermack is our clinician champion. She's one of our primary care team leads and an all-around powerhouse in terms of improving our quality of care and student education. I would say that we've actually got several things we're really proud of beyond surviving COVID in a higher ed and healthcare environment. We stood up telemedicine on a dime and have been adding a lot of technological improvements in an attempt to improve the lived experience of our providers and staff, adding Doximity. We're about to launch with Unite Us. So we've been doing a lot of technological moves, but we also completely from the ground up revamped our care team model with some major improvements. And then we've also built out an entire PCPCH umbrella to hold all of our quality improvement projects, to make sure that all of our projects are feeding into the core values of our PCPCH. So it's been busy, but our providers and our staff have just been amazing.
Incredible. Thank you, Nora. Anyone else ready to hop off mute? Oh, is it Marianne?
Yeah. Hi, everyone. Thanks so much for having me. My name is Marianne DiNapoli. I use she, her pronouns, and I am an OBGYN at the University of Cincinnati. And part of my job is that I also work closely with the Cincinnati Health Department, primary care health centers. I'm very excited to be part of this project. Don't have anybody else on my team on the call today. And the thing that I'm most proud of that we've developed at our health centers the past couple of years is a colposcopy program. And we previously would have to refer all of our abnormal paps out to the university, but I've established a colpo program right at our community health center. So patients can get their colpos done at their medical home to improve compliance. And so that's made a huge difference in our patients' lives.
That's awesome. Thanks, Marianne. Ready? I see Leanne, you ready to intro?
Yeah, sure. Can you hear me?
Can hear you just fine. Yep.
Awesome. So my name is Leanne Marco Giorgiano. I use she, her pronouns. I'm at La Clinica in Oakland. I'm a family doctor. And I don't have, unfortunately, anyone else on the call, and I apologize. I'm kind of multitasking because my schedule wasn't changed, so you'll see me sort of here and there. We, over the last couple of years, like everyone's saying, have been like COVID responding, and I think our biggest win would be that we've screened and vaccinated a lot of folks in the East Bay community, specifically in Fruitvale. So it's been like a huge, huge win for La Clinica. Like everybody else in FQHCs, like staffing has been hard, so we're rebounding from that. I think finally stabilizing a little, but just still moving forward, taking a little bit of a breath of fresh air. But things are good. Excited about this learning community and hanging out with all of you.
Thank you, Leanne. Anyone else ready to come off mute?
Yeah, I can introduce myself. Hi, everybody. I'm Darren Eichner. I'm the Vice President for Service Delivery Improvement at the National Family Planning and Reproductive Health Association. And we're a member organization supporting family planning providers who provide services primarily in the safety net. We've been a proud partner with UCSF for a number of years on these projects, so I'm happy to be here today.
Usually on the team is Elizabeth Jones, has been out on maternity leave, but she'll be back in 2 weeks, so she'll be joining us. And I think over the past couple of years, I'm most proud of our ability to support our members as they really continue to work, as you all do, in very difficult circumstances, you know, in times of COVID, in flat funding, and in very difficult political environments.
Very critical. Thank you so much, Jan.
Hey, I'm happy to jump in.
Yeah, thanks, Ingrid. Go right ahead.
Hi, I'm Ingrid Estrada Darley. I'm the development director at Clínica Romero. Currently kind of sitting in this interim role because we have hired a new family planning manager very recently. And so she is being onboarded, and then we'll take over this project as soon as she's ready to hit the ground running. But I think something that the clinic has really accomplished, and we're in Los Angeles, California, and something that we've been able to accomplish, which I think, you know, we're very proud of, is we actually were able to grow from 2 clinics to 6 clinics this year. So despite all of the challenges of COVID, demand, you know, in our community is high. And so we will be going from seeing roughly about 11,000 patients per year to over 15,000 patients per year. So that's definitely an achievement. And my teammate Norma Bueno, who's our quality improvement manager, is on the call as well. And Dr. Don Garcia, I don't see him, who is our medical director, may be joining shortly, but he gets pulled in 1,000 different directions. So he may have had something come up this morning, but may join at some point.
Totally. Thank you so much, Ingrid. Hi, Norma. Nice to see you. Any other folks want to come off mute? I see Larissa. Are you ready to do an intro? Awesome.
Hi, everyone. So my name is Larissa Rodriguez, and I am the Director of Nursing at Alliance Community Healthcare. And I have with me today Melissa Colon, and she is our Director of Revenue, Billing, and also Operational Leadership. My pronouns are she and her. I don't think I have anything more to say. I mean, our accomplishments have not been as great. We have survived COVID, and we are currently in our, let's say, road to be able to provide the Genius vaccine to our patients. So we're waiting for that to come in. We have been providing the vaccine to some patients because we have somewhat of an agreement with the Department of Health from 2 different cities. So they will send their patients to us and bring us the vaccine so we can be the administration site for those patients. What else? What is something that we have accomplished? What else? So we have adopted the workflow for the implementation of the contraceptive counseling initiative. I had mentioned previously that we developed a we used the QR code, and we developed somewhat of a workflow where the medical assistant will come in the room and make sure that the patient scans the barcode before they leave the room. Right after the provider sees the patient, and that has helped us bring our numbers up and keep up with that. We continue to engage and train our staff to ensure understanding of the needs and the workflow of the contraceptive initiative, and also providing them with engagement strategies and guidance, and also feedback to improve the workflow, and also future training. So that's all.
That's great. Those are great accomplishments. And anyone else want to say hello? I think I saw Yael come off mute. I don't know if you want to give an introduction.
Sure. Hi, everybody. I'm Yael Eskenazi. I'm the Director of Reproductive Health at Chase Brexton Healthcare. We're in Baltimore, Maryland. I use she, her pronouns, and I think I'm the only person from Chase Brexton on the call today. But Leah Hart, the Medical Director of Population and Health, who's also involved in this initiative. She and I, a few years ago, led an initiative at Chase Brexton to floor stock LARC devices across all the clinics to decrease barriers for patients, and that was successful. So we're happy about that. Thanks.
Thanks so much. Anyone we're missing? I don't think we heard from our Western youth folks. Did we? Or did we hear? Yes, Stephanie, I heard from you first. Anyone else that we haven't heard from on the call? Let me take a look there. See a couple of HCCN folks, if they wanted to come off and just say quick hi. You don't have to go through the whole spiel, but if you just want to, say hello and give your name and pronouns, that would be great.
Okay, I'll say hello. I'm Michelle Tropper with Health Efficient. And I see from our team, we also have Christopher Upman on the call as well. I use she, her pronouns, and I am really proud of our members and all the efforts they've put in to get those surveys in. It's been amazing to see the progress over the last couple of months. So I just want to give a big shout out and kudos to all of your hard work and efforts in getting those completed.
Absolutely. Echoing that, definitely so proud of folks getting in all their PCCs.
I can go too.
Sure, thanks,
everyone. My name is Seren. I'm a clinical program specialist here at OCHIN, and I'm the only one on the call today, but I have been supporting this project with Amory and Michelle, who are medical informaticists, and some other folks helping us with data like Craig. And I use she, her pronouns, and I think I would echo what Michelle said. I'm proud of all the work that everyone's put in and all the effort to kind of get these surveys, and just in general, all the different improvements you all are proud of. It was really nice to hear, and happy to be able to support in any way. Thank you.
Awesome. Thanks so much, Seren. Yeah, it's great to hear, we are focused on contraceptive care in this project, but it's like so excellent to hear. I know, like we've mentioned before, there's so many things that have been happening, and specifically with COVID and people being stretched to capacity. So hearing about all of your excellent accomplishments, even outside of contraceptive care, is just so heartwarming, and it really puts a lot of context to this project. Thanks so much, y'all. I think we're ready to move on to our next section. Thanks, Sonia, for bringing our slide deck back up. Awesome. So at this time, I'm going to hand over the mic to Jamie, who will be leading us through this next section on equity and performance measures. Jamie, are you ready?
I am ready. Can you hear me?
Awesome. Can hear you just fine.
All right, great. Good morning, everyone. I think it's morning in most people's locations. I'm going to talk to you about equity and performance measures. And why don't we go ahead and go to the next slide. I wanted to start by just a reminder of why we actually measure performance and why this is something that we're here talking about. And there's I think a whole range of reasons, from providing a consistent approach to assessment to thinking about how to look at gaps in quality and inform QI efforts, which is one of the primary focus areas of this initiative. I think also importantly here, it's about increasing access to methods and quality and patient-centered contraceptive care. And so part of that is including helping individuals make informed choices about where they get their health care. I think another piece that sometimes isn't talked about is how important performance measurement is in ensuring that sexual and reproductive health services are prioritized, so that, as in other areas of care like chronic disease management and preventive health screenings, and that sexual and reproductive health care becomes part of kind of the fabric of healthcare and the norm versus an add-on or something separate. And I think lastly, I'd say, if we're trying to reach the goal, which I hope we are across the country, about patient-centered care as a standard of care, that it's not easy. It's going to require a major transformation of healthcare systems and norms, and it's not a simple process. And thinking about performance measures is a part of that transformation. And specifically for contraceptive care measures, the early work really focused on the goals of increasing access to contraceptive methods and to quality patient-centered contraceptive care, which is sort of the frame of the work you're going to talk about in the measures in this project. There also is nationally quite a bit of movement and interest in adapting existing measures for new contexts, like thinking about the PCCC measure in the peripartum context, and for thinking about new measures that prioritize people's sexual and reproductive health experiences. For example, one of the things that we're working on with PCRHP is developing, and the National Birth Equity Center is developing a measure for sexual and reproductive well-being. So in addition to the measures that exist, there's also, I think, work to really think about the ecosystem of measurement and how to look at people's experiences more holistically and comprehensively. Next slide, please. So measurement, however, can still cause harm. It's not always the answer to everything. And so what I want to talk about today are two potential effects of measurement in contraceptive care. One is about the incentive to, the possibility to incentivize non-patient-centered care, and the other is about potentially exacerbating reproductive injustices, which is where I'm going to start on the next slide, please. So there's a lot that's been written about, a lot that's been talked about in terms of historical reproductive injustices as well as contemporary. And I think just as a reminder to people, and I always say when I do this slide, it does it a disservice to have this 4 bullets on one slide. But this is at least getting some of these concepts and these ideas out there. And I think it's really important in the context of our work to remember what this history has looked like. And so from non-consensual sterilization of poor women and women of color throughout the 1900s, targeted marketing of things like LARC and long-acting contraceptives in certain communities, unethical testing of oral contraceptive pills in Puerto Rico in the 1950s, and then between 2006 and 2010, coercive sterilization of 150 incarcerated women in California. That's not that long ago. This is all, most of this is within our lifetimes. And I think the other piece, next slide, please, is that it isn't just history, and that performance measurement, what's important to remember is, they're tools, they're blunt tools that can really work to incentivize patient-centered care or sometimes incentivize non-patient-centered care. And I would say before we get into the discussion of specifics to contraception, is that it's not a problem that's unique to contraception. So there are examples of where patients were forcibly transferred out of practices for noncompliance to get higher scores on specific metrics like hypertension or diabetes. There are also examples of where women were being tested for chlamydia without consent to meet chlamydia testing metrics. So there's a range of things that can happen. And I think the other piece I'd like to mention is that for contraceptive care, what can happen is that measures can deprioritize an individual's values and preferences, especially related to a method that's not considered to be high or moderately effective, like condoms or fertility awareness-based methods. And what I'm going to ask Christine to jump in here because of some of the work that they've been doing at PCRHP and UCSF about ongoing evidence of differential counseling and bias. So Christine, do you want to jump in?
Yeah, thank you so much, Jamie. I think that we really wanted to lead with this to ground this effort in the concept of advancing health equity, recognizing the potential for harm when we're doing an initiative within a healthcare system writ large that hasn't always held up reproductive autonomy as being the most important end goal, implicitly or explicitly. And the evidence that this is ongoing in history, in our current healthcare system, has included studies, for example, that have found that low-income women of color are more likely to be advised to limit their family size. They're more likely to be pressured to use Black patients specifically are more likely to report having been pressured to use contraception. And also that we found the one study of 500 Black women found that 67% of them reported race-based discrimination when receiving family planning care. I want to point out, similar to what Jamie said about this not being a problem unique to reproductive health care, this differential treatment by race ethnicity is something that's true throughout healthcare and has actually been most prominently documented in cardiology. But we see this in the context of reproduction, which is obviously an incredibly personal and sensitive area of healthcare. And it's therefore obviously, as we're doing initiatives related to contraceptive care, we need to keep this history in mind. And we, as Jamie mentioned, next slide, at PCRHP, we did a study where we actually were interested in IUDs specifically because they are a method that has relatively, in the last few decades, really been something that has garnered a lot of enthusiasm from healthcare providers. And we wanted to see if this enthusiasm was differential by race ethnicity. So we created these videos of standardized patients that differed by race ethnicity and was the same in all other ways, standardized delivery, standardized language, background, et cetera. And what we found, next slide, when these standardized videos were shown to providers at the American Academy of Family Physicians and ACOG national meetings in a randomized way. And what we found was that providers were more likely to recommend the IUD to women who are Black and Latina as opposed to white women. And again, this is controlling for all other variables. So it shows us that there is a need to really attend to how racial and bias around race and ethnicity can show up in the clinical context, and how we need to be particularly conscious of that when we're doing performance measurement and quality improvement in order to make sure that we advance the needle towards health equity. Back to you, Jamie.
Great, thank you. Next slide, please. And so I wanted to just a couple more slides for this part, but what I wanted to talk about next is why equity and how equity is really relevant to the work that we do, that you all are doing. And this is a definition that's based on a lot of other concepts and definitions like reproductive justice. And at SICA, we did a comparative analysis of all these different foundational constructs that currently shape sexual and reproductive healthcare policy, and convened an interdisciplinary technical expert panel in spring of 2020. And so we think a lot about the definition and what it means to actually make it happen. And so to really achieve SRHE, and what I want to leave you all with is to think about how part of it is acknowledging and understanding all the historical and contemporary context of how inequities structure the experiences of people, and particularly people that have been historically and are still marginalized today. And I think the other piece, and why this work that Christine's going to talk about today around measurement is so critical, is that we have to really think about shifting the work we're doing away from some of the frameworks that traditionally have guided the work we do around sexual and reproductive health to more meaningful ones. And so that I think what I would really encourage you to do is, as you're working through this learning collaborative, is to really think about what matters. What are the processes, what are the structures and the outcomes that are important, and then that are considered worth funding and measuring. And the work that you do on the ground can influence what we talk about at the national level and vice versa. So it's so critical to have learning collaboratives like this, to hear about your really wonderful experiences, your challenging experiences, because we can take that up another level and change policy and the way that programs are funded. And what I mean by moving away from frameworks, an example would be, you're going to talk today about how to move away from asking questions solely about pregnancy intention to thinking about contraceptive need that's identified by individuals. So even that shift in thinking changes the way that we're framing and measuring and funding contraceptive care. So that's the important part. And then lastly, I think what I would say for this slide is just thinking about, as I mentioned before, that range of measures that really prioritize people's experience of reproduction more holistically and more comprehensively. And then these measures, the reason we want to have this broader group of measures is to think about and do a better job of incentivizing the care that we really want to provide. It's not measurement for the sake of measurement, but it's ultimately to get the care that we want for our clients, for our patients, for individuals. And then my last slide is just about what we're hearing from the field in terms of how, oops, I actually did that slide. It's the next slide. There we go. So I think what we're hearing from the field, what's required to really make this shift happen, both, at the, or I should say national level, state level, local, clinic level, et cetera, is that there needs to be a real shift in culture and alignment of goals. And so one of the things that we're trying to look at nationally is to think about messaging about the need for the benefits of and intended use of measures, and sharing, like I said, success stories and promising practices and patient feedback. So big picture, we need to think about how we shift that culture, and that can be within your network. It can be within your facility. It's at the broader state level, national level too. I think the other piece is that there's a real need to support use and implementation. And so a focus on developing, consolidated resources for specific measures and for tandem use, and enhanced training, technical assistance, and quality improvement, and things like this learning collaborative. So we can shift culture all we want, but if we aren't working with people to provide the tools and the guidance and be able to incorporate that feedback, we're not going to change the way that we do the work. So that leads into the last part about tracking, reporting, and improving measures. And so I think it's so critical to think about how you are tracking this at your individual sites, within your health centers, within your networks, and then how do we integrate that nationally across systems and programs. So what, I think you all have probably a range of funding sources. So what does that mean for Title X to integrate patient-centered care, to the PCCC, to integrate the PCCC into FPAR? What does it mean for HRSA to integrate the use of contraceptive measurement into UDS? So what does it mean for CMS to look at these things in terms of, measure sets, et cetera? And sorry, yes, FPAR is UDS data similarly to Title X clinics. And I think that's what, I'd leave you with today is the way that we're incentivizing monitoring and evaluating kind of the uptake, that there's so much information that we can gather from this, and then think about how we really change the systems. And I think that this process of making sure you're thinking about equity from the start as you're designing, how the measures get worked into your systems, how you're tracking that, and how you use it from quality improvement is what's going to make some real change. So with that, I will turn it back to the PCRHP team.
Thank you so much, Jamie. There's such incredible food for thought in your section, and we'll definitely leave some space and time for questions at the end. If folks have any, feel free to pop them in the chat if you don't want to forget them, and we can come back to them at the end. At this time, I'll turn the mic over to Christine, who will walk us through using performance measures in contraceptive care.
Great. Thank you, Lindsay. And thank you so much, Jamie. We're so grateful to SICA, Jamie's organization, and NIFRA, Darren's organization, for their partnership on this project, because as Jamie said, we really recognize measurement is important, but needs to be done carefully and well if it's not going to cause harm. And the work that we're doing here is something that we absolutely want to use as a lever to improve things on a national level in terms of care delivery, quality improvement, policy, along with our national partners. So this is really going to, this work that you're all doing, in addition to being hopefully instrumental and important at your own site, will also be something that is going to contribute to the national conversation about how to do a better, more nuanced job around performance measures in general, and particularly in reproductive health. So thank you so much for your partnership on this. We couldn't do this without you. So I just want to step back and say, what is quality in contraceptive care? When we're talking about doing quality improvement, it's kind of important to know what we want, right? What is the end goal of this? So we wanted to ground this performance measurement work in our understanding of quality. So we know quality is complex, but I will tell you that there actually are federal guidelines. For those of you that are Title X clinics, you know this, federal guidelines for quality and contraceptive care called the QFP, or Quality Family Planning Recommendations, that were published by the CDC and the Office of Population Affairs. And it's a long document. Jamie was very influential in its creation, but included in this document are some core principles, including that patients, or clients in Title X language, patients in ours, should have access to a broad range of contraceptive methods, preferably on a same-day on-site basis. So access to methods is critical. And that these services and access to these methods need to be done in a patient-centered way, focused on the patient's own preferences and values. And so we're going to keep coming back to these two principles of access to methods and patient-centeredness, person-centeredness of care delivery as the kind of twin pillars of what we sometimes call the tandem use project in our own parlance, these two things together. Because so often we know that performance measurement is done on one thing. And then when that one thing is done, then we kind of fall away. What we really want to do is take a more multifaceted approach to what quality in contraceptive care means by looking at both of these two things together. So what do we know about the need for quality improvement in quality of care and contraception? So we do know from the literature, from lived experience in our own health centers, from talking to people, that there are gaps in the quality of care. We could do a better job as a health system in helping people to achieve their reproductive goals. Gaps in quality of care that have been identified include that many patients aren't screened for their reproductive needs. They come in for something and that's their only healthcare visit in a year, 2 years, 3 years. They don't get asked about if they have any reproductive needs, so they don't get those needs met. Another thing that happens is people don't have access to methods. Obviously, there's financial barriers to access, and I want to acknowledge that. And that's something we can and talk about in this learning community. But even when there are some financial access, oftentimes there's not access for other reasons, including things like stalking and barriers of multiple visits and unnecessary testing before getting an RUD inserted, for example. And then we also know, and I'll talk about this more later, that there's room for improvement that we know is there in the patient-centeredness in that aspect of care delivery and how well we are focusing on people's own needs and preferences when providing care. Okay, so we know, I hopefully have convinced you that we should be focusing on quality in a multifaceted way in contraceptive care and that there's room for improvement in contraceptive care. But why with community health centers specifically? Why, in addition to the fact that I'm a family doc and deeply believe in the mission of community health centers, why are you all so critical to this effort in quality improvement? Well, we know that community health centers care for patients across the life course, including many, many aspects of their reproductive lives, right? We had that referenced earlier with the Colpo example from Cincinnati. So we care for patients, and one of the ways we need to be caring for patients is with respect to their need for pregnancy prevention. That is a core aspect of people's reproductive life experiences. And we also know from literature and also our lived experience that patients really value getting their reproductive health care needs from us. Even if there is dedicated family planning clinics, say, down the road, some patients will want to use those, but other patients will want to come, many patients want to come to their trusted patient-centered medical home to get their reproductive health care. And so if we aren't clear that we're providing those services, then they might not get it where they most want to get it, which is an aspect of patient-centeredness. But we also know that we do a lot of things. This was also referenced in what you all said earlier. Community health centers are the backbone of our healthcare system, and particularly our safety net healthcare system. We have seen that never seen that more obviously than with the COVID pandemic. So we have a lot of things going on. And when there's a lot of things that are going on, sometimes things that aren't front of mind get pushed to the sidelines. And that's just the reality. We've seen that in the COVID pandemic. And the honest truth is that contraceptive care hasn't been as prioritized in general in primary care and community health center delivery. And then I would also say this is particularly relevant because we care for a lot of really medically complex people, right? We care for people with comorbidities that influence their reproductive lives, that influence what methods they can use. So providing care to those people is absolutely critical. And then finally, to tell you something that you all know, health equity and social justice is central to the mission of community health centers. And so meeting people's reproductive health needs, promoting their reproductive autonomy is something that is so consistent with what we do, and that we are so well equipped to be in service of our patients in advancing those end goals and in living in accordance with those values. Okay. So how do we do quality improvement in contraceptive care? So we need to measure it, as Jamie already said. We have to know what we're going for so we can track it, right? So we can track, are we getting to our end goal? And that requires nuanced measures that capture both of these two pillars of reproductive health care, right? Of quality contraceptive care, access to care and patient-centeredness. We want to be able to do both of those. It is absolutely critical, though, that when we measure access to contraceptive care, we do that not assuming that everyone will want to use contraception, because that is exactly antithetical to a concept of patient-centeredness. And that is actually what many current measures, both in the international context, such as concept of unmet need, which is basically anyone of reproductive age who isn't using contraception has unmet need. It's a little bit more nuanced than that, but not much. And our current claims-based performance measures for contraception puts everyone who's not pregnant in the denominator. And the advantage of electronic health record data is that we can do a better job by excluding those who don't want contraceptive care from the denominator, and therefore measuring quality, not from whether we're providing contraception to everyone, whether or not they want it, but whether we're providing contraception to those who want it, which is actually what we ultimately care about. And so this, if we don't do that, it could incentivize, as Jamie already referenced, problematic and directive counseling. Next slide. And I'm going to come back to that later, because that is really the concern about how we're measuring access is what has motivated our self-identified need for contraception question that you all are implementing in your health IT and clinical workflows. So we will talk more about that later. But I just want to make the case that also tell you that it's really important in performance measurement, as Jamie already referenced, because we have seen that performance measurement, when not done in an appropriately nuanced way, can be problematic and incentivize non-patient care, including the transferring patients, as Jamie referenced, and also a really common practice of testing patients' urine for chlamydia without consent in order to meet testing thresholds for STI testing based on CDC guidelines. And this is something that we've seen in San Francisco without telling patients we're testing them. And so we have to be really careful, because when you use a blunt tool, which measurements are always a blunt tool, you can get unintentional consequences. And so when we're doing this performance measurement work, we want to continue to keep top of mind this potential, because we really want to make sure that, like I said before, we're moving the needle towards health equity. Okay, next slide. All right. Sonia or Lindsay, do you want to launch the poll?
Sure thing. So again, the poll question: has your site or your clinic done a patient experience survey in the past? It can be any type of patient experience survey. Awesome. Seeing so many responses come in. Dr. Garcia, I'm going to mute you. We're getting a little feedback from your line. Awesome. Seeing 15, 16 responses. Overwhelmingly, it looks like folks have done general patient experience surveys before. If anyone wants to come off mute, maybe give an example of one that you've done before, and share the results.
I'd be particularly interested if anyone wanted, I think maybe it's one person who's done patient experience surveys for specific types of care. Could you share that experience other than the PCCC, I'm assuming? Well, I just wanted to connect the dots there, that actually what we've seen in the literature on patient-centered care is that there has been a focus on general patient experience surveys, right? The CAPS survey is something that's very frequently used, right? The Consumer Assessment of Health Providers. I can never remember what the exact acronym is. But there's been less focus on specific aspects of care. And the reality is that reproductive health care is a very unique aspect of care experience. It touches on areas of sexuality, intimacy, fertility, relationships, all these things, right? And when we're doing quality improvement, therefore, in the context of contraception, that we have the potential to disturb or worsen existing tendencies towards not paying adequate attention. Thank you, Lindsay. Not paying adequate attention to these personal and sensitive aspects of patient care, of patient experience, of contraceptive care. In addition, as we already said, there is this reality of differential treatment by race ethnicity in healthcare related to reproduction. And so it is particularly important from a health equity perspective to lift up patient experience in this context so as to avoid these negative unintentional consequences. So the survey responses really reflected what we expected to see, which is there has been a general attention to patient experience, although it can be debatable how adequate that has been. But this move towards measuring patient experience in a specific aspect of care, focusing on reproductive health and contraceptive care, is at the forefront of quality measurement. And so this is why, again, this work is so important, because it has the potential to influence quality measurement more broadly in terms of understanding quality from a multifactorial context, and specifically in contraceptive care by really focusing in on experience in this particular aspect of care. So thank you for your answers. Next slide. Okay, so this is the PCCC, which you all hope are intimately familiar with at this point. The PCCC is the Person-Centered Contraceptive Counseling Survey. Started saying PCCC because we got lost in the number of C's if we tried to say it out, PCCC. So it's the PCCC. And this is the measure that you all have been implementing as perhaps your first specific condition-specific patient experience survey. And we really developed this as a labor of love at our team over the past 10 years in order to be able to lift up patient experience in this particular aspect of care. Next slide. And it's really important that we recognize patient-centered counseling is a quality indicator in its own right. It's not only a means to an end. It's not only like we're meeting patients' needs with respect to their needs, values, and preferences so we can get them on a contraceptive method. That is not the goal. The goal is recognizing that patient-centered care, which the Institute of Medicine defines as care that is respectful of and responsive to individual patient preferences, needs, and values, is something that is a core dimension of quality, again, as defined by the Institute of Medicine. Next slide. Okay, and so, no, sorry, back. In the context of contraception, patient experience, as I already said, is incredibly critical. So this personal and intimate considerations I already talked about. In addition, there are documented gaps in patient-centeredness in contraceptive care. So we know that, for example, communication and patient-centeredness have lower ratings than other aspects of family planning quality. For example, things like access to appointments or physical comfort were other aspects of quality that were measured in this study, but communication and patient-centeredness received lower scores. We also know in our study, we audio recorded contraceptive counseling visits at clinics throughout the San Francisco Bay Area. And we found that patient preferences were elicited in less than 50% of the visits. So you can't focus your care on patients' needs, values, and preferences if you're not even finding out what they are, right? So there's a gap there that we documented in this objective audio recording study. And we've also seen that this is something that, for those of you who are in the family planning field or aware of this have seen, but those of you who may be a little bit more in the general primary care field, there has been this incredible enthusiasm / over-enthusiasm for IUDs and implants over the past 2 decades in our field that has led to many providers actually actively promoting IUDs and implants in problematic ways towards patients in ways that are not consistent with reproductive autonomy. We could do a multi-hour session on this, and I know we'll touch on this in the next session. This has also included provider resistance to removing IUDs and implants when patients come in asking for them to be removed in a way that is completely inconsistent with reproductive autonomy. So for all of these reasons, because reproductive health care is particularly important particularly sensitive and personal, because of the implications for health equity and reproductive autonomy, and because we know that we are not currently as a healthcare system writ large doing a good job with patient-centeredness and contraceptive care, we need to really be focusing explicitly on patient experience in this aspect of care. And the next slide, this is just a quote from a study that was done out of South Carolina that was looking at experiences of contraceptive counseling in the context of an initiative to promote IUDs and implants. And this one quote really summarized a big aspect of the study, a big finding of the study, which was that patients were receiving this initiative in a way that made them feel like they were like basically being treated to a propaganda effort about these methods, as opposed to having their own needs, values, and preferences focused on, and that they were receiving it in a way that really interfered with their trust and ongoing relationship with the healthcare system. So this slide is very busy, but we put it up here just to let you know, we did a lot of work over the last decade, like I said, on the PCCC to make sure that it represented what patients think. And that's the 3 domains on the on one side, the interpersonal connection, adequate information, decision support, what patients value in contraceptive care based on qualitative data. And then we did really intense combination qualitative and quantitative work together to make sure that what we came out with represented what patients want out of contraceptive care, what's actionable for providers and quality improvement administrators, and also is feasible to implement in the contraceptive, in the family planning and primary care context. And we initially started with 21 items, for example, and we did all this work to get it down to 4 items that most parsimoniously captures patient experience of contraceptive care. Next slide. Okay, so that is why you're doing the PCCC. That's why you've worked so hard to collect this data over the past couple months. And thank you so much for doing that. And so we want you to know that you are going to be getting those results from us. And we've been doing a lot of thinking about how to operationalize this results to you in a way that is most helpful to you and where you can use the hard effort you've put in to understand how you're doing with respect to patient-centeredness with the goal of identifying potential opportunities for improvement. So you will get a sample report that will look something like this. It'll vary a little bit based on your own, the number of, for example, racial ethnic categories that we can comfortably stratify on without being concerned about potential disclosure of who gave a specific score, right? Or the number of sites that you have. But this will be more or less what it is. And then next slide. So this will be the kind of heart of it on the front page, right? So you will see the number of PCCCs you collected. This sample clinic did exactly 50, went right for the goal of 50 responses. You will see what your overall score is. So the overall score is the percentage of people who responded all 5s, all excellent on the 4 items. That is the definition of a positive score. So this sample clinic, 65% of people answered all 5s. I know that seems like a high bar, all 5s, top box score. Thank you, Lindsay. In our initial work with this clinics across the country, we saw ranges up to 99% for providers and patients of people receiving all 5s. So while it is definitely something that we expect to be it's not necessarily going to be 100% or 99% for everybody, but it is something that is absolutely feasible to do. And actually having this top box scoring system is consistent with how CAPS does their scoring, and also is just consistent with the general finding in patient experience literature that things have to be pretty noticeable for patients to give anything less than excellent. There's such a strong social acceptability bias that patients often don't report anything unless it was really something that they as less than excellent, unless it was something that was really significant for them. And then you can see on this slide, you can see that we will also disaggregate it by specific items. So you can see if there's a specific item that perhaps you want to drill down on that maybe is driving your scores being higher or lower than what we've set as the threshold goal of 80%. Next slide. Okay, so that's what you're going to be getting from us, and that's that's one of the pieces of data we're going to be working with over the next couple, many months together. Just a couple quick things about the PCCC. In the prenatal and postpartum context, Jamie already referenced, this hasn't been validated in that context, particularly because it's a visit-specific measure, and contraceptive care and peripartum care is usually delivered at multiple touch points. But we are working on developing a peripartum measure, so just know that that's the case. And then in terms of working with trans populations and cisgendered men, it's absolutely not a gender-specific measure. So it absolutely can be used across populations. And we're interested in learning from you all as you implement it in different contexts, what that looks like for you. We will be, for the performance measure context, reporting it from those who identify as female in the medical record, because that is the way that it has been validated. But we are really interested and want to work with you all to understand more nuanced and inclusive ways of thinking about this down the road. All right, next slide. Okay, so that was the patient-centeredness kind of pillar that I was talking about. That's one of the performance measures we're using in this project. The other one, as we referenced, is the sync-based ECQM. ECQM is electronic clinical quality measure. So that's using EHR data to measure contraceptive use. And SYNC is the self-identified need for contraceptive. And I'm going to talk more about that. And overall, this is designed to serve as a proxy for access, because you can't go in and do ethnography at every clinic to see if every patient is having access. This is a way to capture this in as feasible and patient-centered a way as possible. So you all will be getting this data. The numerator is those receiving or documented to be using a contraceptive method during the calendar year, recognizing that it's about patients getting their needs met and you knowing that they've gotten their needs met, as opposed to necessarily you being the one to put in the IUD. And then the denominator is women, female identified patients in the EHR of reproductive age. 15 to 44 is the definition that's used most commonly, excluding those who said that they didn't want contraceptive services per the SYNC question. And that's really, again, the desire to make sure we're capturing this among people who want to be using contraception, not among everybody with any assumptions about what people should be wanting. Next slide. So again, hopefully you all have seen this. I know it's built into the various EHRs, Epic, and to great question, Deanna, I will get back to that. Epic and ECW and Chase Brexton, I'm sorry, I'm forgetting exactly what your EHR is, but your EHR as well. And the idea behind this is that it's built into standardized workflows and in the EHR template to capture it. We ask everyone about their reproductive health needs. Do you want to talk about contraception or pregnancy prevention during your visit today, with these response options? So I want to just really say, I could talk for an hour about this particular question and how much work went into designing this question. But as Jamie already referenced, we really wanted to move away from a question about patient intentions for pregnancy over the next year, which then we would use to kind of make assumptions based on what they want right now, to really asking people what they want right now, because that's what's most important, right? And that actually is consistent with the literature from a patient-centered perspective about what patients want. How they want their reproductive health needs identified is by having the question be about their reproductive health needs. We also worked with reproductive justice leaders, Dr. Joya Creer-Perry and Dr. Jamila Parrott, to develop this question and implementation guidance to really make sure that, again, anytime you implement standardized workflows, it has the potential to cause harm. So we wanted to make sure that we were thinking about this in a very careful way. For example, making it clear that the only answer, that it's not that if you say no, you don't want to talk about it, it has to be because you're using another method of contraception. So we didn't put that answer first in the answer options, right? We put, I'm here for something else, to make it clear that we want to be absolutely explicit that people can say they don't want contraception for any reason. And it is about what they want, not about what we think they should want, that we are foregrounding with this question. We want to identify their needs, but not reenact ongoing harms through asking this question by reinforcing problematic narratives about reproductive autonomy and people's reproductive choices. Happy to answer more questions about that. Next slide. So I already said this, but it's really, to be clear, we really wanted to make sure by putting this question out into the world, it could be used to facilitate patient-centered workflows and facilitate patient-centered and reproductive autonomy consistent narratives about reproductive health needs, as opposed to interfering with them, in addition to facilitating patient-centered measurement of contraceptive access. So it serves the dual goal, because as we can't just do measurement for the sake of measurement, and we can't do measurement that interferes with patient care. They should actually be mutually reinforcing. All right, Lindsay.
Awesome. So a poll should be popping up on your screen. And the question for this poll: how frequently, when people come in for an acute care visit, so something like asthma or migraine, are clinicians asking about their reproductive and contraceptive needs?
And while you're answering that question, I'm going to answer Deanna's question. So we actually have developed separate ECQMs for people who are currently pregnant in a given year versus people who are not. And that is, and then both of the questions, both of those measures include SYNC, the self-identified need for contraception. So patients who are postpartum and say they don't want to use contraception, they also get removed from the peripartum measure as well. So while this particular project, we have primarily focused with you all on sync in the context of people who are not currently pregnant. We actually would encourage you and would love to see you implementing this as part of standard postpartum care as well, as a way to facilitate patient-centeredness, recognizing that many patients, when they're postpartum, there's often an assumption about they should prevent pregnancy, but many people are not having sex that could produce a pregnancy, are using non-prescription methods, are experienced infertility. So there's a lot of reasons why implementing this also is a patient-centered approach to peripartum care as well.
Great, thank you, Christine. This is incredible. We have 100% of answers as sometimes, I spoke too soon. One person said never. So it sounds like not very often, right? So when people come in, clinicians are asking about reproductive and contraceptive needs, which is interesting. I don't know if anyone wants to come off chat and say a little bit about their answer selection. A lot of sometimes folks here and one person saying never.
Okay. Great. Well, thank you for that. And I think this is really our idea with sync is by asking it once a year, at least, right? Even if you don't have time in the asthma visit or the migraine visit to address it, you identify they want to talk about it and you can schedule them to come back, right? And it doesn't leave it dependent on individual clinician workflows and decision-making to ask the question, but it actually gets baked in a way that can facilitate patients getting their needs met. Great. So really quickly, because I know we're a little bit behind schedule, those are the two performance measures, right? We have the PCCC and the ECQM. No, you can go on, it's okay. And the goal of this project is to help you, support you all in your ongoing efforts around health equity and patient-centeredness to use these two measures to identify opportunities for quality improvement. So you can get baseline measures that will that you can use to decide what quality interventions you might want to implement over the course of this learning collaborative. And then we will help you and work with you to track these measures over time. So just to give you an example on the next slide. So very busy, I know, but if you focus on, I'm going to use my annotation because I love this. If you focus on this square, which is somebody who has a low percentage, a clinic that has a low percentage of most MOD methods and a low PCCC score, right? So you can improve both the patient-centeredness of care and access to methods, right? So you should look at opportunities to improve access and opportunities to improve counseling. Alternatively, what if you have high scores on both, right? Are you just good and you're done? Sure, you could say that, but I would actually encourage you to think, okay, are there opportunities to advance health equity? Are there opportunities to look at, by looking by race, ethnicity, by age, by ability status? Are there things that we could be doing to enhance our method mix? Does it look like, oh, actually 90% of patients with this one clinic are using Depo? Maybe that's because they want it, but let's look a little bit more closely. So there's opportunities to use contraceptive methods, to use these performance measures as a starting point to explore in more depth. And then of course, if you have high on methods and low on patient-centeredness, you want to look at your counseling approaches. And if you have the alternative of high on patient-centeredness on low of methods, you might want to look and see, are you screening patients consistently? Do you have same-day access to LARC and those types of scores? Okay. Yes, you can absolutely have a copy, Heather. We would love it if you showed this with your staff. Okay, and then like I said, we are going to be giving you these measures back to you, the ECQMs and the PCCC. We want to hear from you. What's helpful? What do you want to know more about these measures? What is worthwhile for you in terms of allowing you to dig in and use this for QI? Because that is the learning we're going to get out of this in addition to supporting the efforts that you have. So those are the kind of things we want to talk about in our TA sessions, in emails, all of that, to really understand how we can best support your use and understanding of this data. Great. And I will hand it back to Lindsay. Thank you all. I'm sure you're so sick of hearing from me. I really appreciate your time.
Never. Thank you so much, Christine. That was really helpful and informative. We're at 9:43 Pacific time right now, so we can take some time and have a discussion on PCCC. So for folks who are completed with their PCCC collection, or perhaps you're trying to get a couple last PCCCs in. Any lessons that you learned from collecting these PCCCs? How did the run go for your site? Are there any plans that you'd want to change the way that you collected your surveys, or any lessons that you learned that you'd want to share with us? We'd be more than happy if you want to come off mute and say anything about your collection for PCCC. We also were interested in knowing, are folks interested in continuing to collect PCCCs? So, we'll have the opportunity to continue to analyze data for sites, thinking potentially on a monthly basis. If that's something that your site is interested in, again, the threshold for calculation of PCCC is 50 surveys. So it could be monthly if you're able to collect 50 per month, or on another schedule that would benefit your site. So if you're interested in continuing to collect PCCC, let us know. We'd be happy to help facilitate that. But yeah, now that we are off the slide deck, we can all see each other. Any folks want to share their experience in collecting PCCC? And I will copy and paste those questions in the chat so that we can see them.
Hey, this is Jody from Hometown. So I guess I'll just go into, we struggled definitely the first couple of months collecting everything. We had the QR code posted up in a couple patient rooms. We utilized ECW as our EHR. So we used patient registry and then search the parameters of like ages, female, all that. And we were able to pull up about 20,000 patients. From there, we kind of did blast text messages every once in a while. And, it was a really big struggle because you get that kind of like exhaustion from patients getting like, oh, another survey. So we ended up meeting up with Christine and Becky and everybody else. And it was a really good learning opportunity because Christine was actually had a great idea in terms of rewording the way we were approaching patients in the text messages that were being sent out. My angle was a little bland. It was like, hey, fill out this survey. And Christine had a great idea. She's like, put some action words in there in terms of asking like, hey, change your community, help us make contraceptive care, family planning a little bit better. And when I did that, the turnaround was much higher. I think we got maybe 10 surveys more than we were normally getting when we were sending out those blasts. So definitely love Christine for sure. Right now, I think for us, one of the struggles that we had was when we were going through the entire project was, we were initially under the idea that it just had to be 50 yes surveys. We didn't understand the full context in terms of like, we need to have these questions say yes. So I think in terms of like being a little bit more specific on what we need in order to get that information processed and make sure that we're all on the same page, I think that's super important. But, we were able to get a little bit more time and we're still processing those surveys. But I mean, besides that, again, that iPad, all I did was work with my IT director. We bookmarked the survey on like a Safari favorite. So all they have to do is go in on the iPad, click on Safari, and then it opens up the bookmark and it leads directly to the link of the website. So Dr. Clemente, who I work with, she'll hand the patient the iPad, kind of have them fill it out. So that way it's right then and there. And then you don't have to deal with having the patient fill it out on paper and then have to worry about scanning it in. It just completely eliminates that paper process, which from an IT perspective is absolutely key. I am so done with 1995 and paper. So that's kind of our experience. We're definitely looking forward to closing up shop. I think we only have probably a handful more to collect, but it's definitely been an interesting process in terms of implementing technology and seeing our patients get that contraceptive care and that open conversation that we've had with them.
Totally. Thanks so much for sharing, Jody. And I just want to mention again, the 4 PCCC questions are needed to calculate scores, which is what Jody had mentioned before, needing all the answers for those 4 PCCC questions. Anyone else want to share about their experience collecting? I think I saw Leanne come off mute. Leanne, if you're speaking, we can't hear you. Maybe Leanne's having some technical difficulties. Does anyone else want to share about their PCCC collection? I saw Stephanie, thanks so much for leaving in the chat. I can read this one out. We learned we need to better support MAs during training and found a disconnect between what the MAs thought the survey was and what it actually was. We realized our Wi-Fi is spotty. That's important to know. Patients couldn't access the QR code on their cell phone. So we switched to loading the survey in the room desktops and got better completion rates. Yeah, that is definitely something helpful to realize.
I'll share one other thing also, in that when I'm physically in clinic and like cheering, the rates go up. And when I'm overdoing academic duties, it's like crickets. And I think part of it is because we're pushing, like health maintenance stuff, and we're pushing like diabetes regulation. So it gets a little overwhelming, I think, in primary care clinics. And when I'm there, I can be like, let's look at your list today. Who do you think might be a good person? Like, let's remember to ask them, like trying to just keep people aware of it and letting the MAs know. But really, it like you really do need the champion there full time, or it's just there's too many other things pulling attention. So I think that's been one of our learnings.
Totally. Champion involvement is like so critical to the effort for sure. Oh yeah, go ahead, Christine.
And I would just add, thank you so much for that, Stephanie. And I would just say that one of the things that we really want to emphasize too is that doesn't mean you have to be in clinic every day for the next year necessarily, like pushing this, right? You can if you want, but that we really want to enable you to think of this as potentially an ongoing data collection, and also potentially as a quick strike, like you can collect your data and you collect it at different time points, and you put in that extra elbow grease of those time points when you're really working to collect the data in mass. So I think that shifts the narrative a little for us and for Stephanie and for the clinic staff who are doing it, to think of it as something that potentially could be more of a like intensive effort at a particular point in time.
Any other folks want to share any lessons learned or any plans for reviewing baseline data when it comes to you? Any thoughts on any other PCCC collection items?
Well, something that we implemented, which has helped us in the past in terms of gathering any kind of patient feedback, is that we used promotoras in our clinic. And so we partner with promotoras all of the time for health education and a lot of other services for patients. And so they're very well trusted. And I think it removes the responsibility from staff members, which it's like it could be a big lift as everyone is sharing. And the promotores also just have like a different presence with patients when they are being approached. Like many of our promotoras are patients themselves. And so I think that our patients feel more comfortable being approached about how they, with a survey about how they feel or what they thought about services when it comes to a promotora, rather than like our MA or our providers, et cetera. So that was helpful for this effort, and it's promotoras are always such an asset for us.
Yeah, promotoras forever. They are a great asset to have in any patient-facing work for sure. And Leanne, I saw you wrote in the chat here, we have constant reminders to providers and staff to get completed. Was doing this a lot daily, which helped a lot, was hard to keep up with, totally. And short staffing and turnover makes it hard to do on an ongoing basis for sure. And we will have some like PCCC tips and tricks to send out as part of our follow-up from this call. So any like lessons learned or other tips that we've learned either from literature, from working with you all, we will send that out in a follow-up document after our session. In the interest of time, it's 9:52 Pacific right now. Anyone else have another quick snippet to share on PCCC collection? Not seeing anyone come off mute. Let me just Check out everyone else. Oh, thank you, Stephanie. Thank you all for doing the work. It's incredible to hear about all of your accomplishments so far. Really exciting. Great. So why don't we bring the slides back up, Sonia, and we can go through our last few points here. Great. So do folks have any questions? I'll leave the door open for that, either for Jamie or for Christine on the information that they presented. And just a reminder, like Heather brought up, we will share the slide deck. We're creating a recording, so we can also send that out. Hopefully folks got the pop-up that said we're recording. So we'll be sure to distribute just to our group, we'll distribute the recording. All the resources that we have from today's call will be posted on the website. So we'll also have that in one central location that you can refer back to. So any questions for Christine or Jamie or myself? Chat, not seeing anything. Okay, why don't we move ahead to our next steps and follow-ups. Perfect. So here's our tentative schedule. I've put in our action periods to sort of orient us and when we would want to do some QI work internally in our sites. So our next session we'll be having on October 21st on health equity and racial justice. I'll talk a little bit more about that in the next couple slides. And then just to keep us oriented, again, thinking about QI periods, we know the holidays will be both Thanksgiving and Christmas, Hanukkah, etc. will be busy times for us in our personal lives and in our clinics. So we've extended the first action period to be a month and a half. So starting November 1st and completing around December 15th. These are, again, action periods are when we'll be doing those quick PDSA cycles and testing out some changes in our sites. If you're looking for places to get started and thinking about QI work, definitely check out the website. We have all of our QI strategies listed, as well as a little QI assessment that you can take with your sites. Really important to help highlight areas where you and other staff members are thinking would be good areas to implement some QI and start those PDSA cycles in November. And I did want to just highlight, we still have our topics to be selected by you all for areas where we can dive in a little bit further. We will start collecting your feedback on where you'd like to go with those topics starting in the next session. So please do think about, where you'd like to see us go with these sessions, and we'll definitely be collecting that information in our next session. Next slide, please. So for next steps, until we meet again, we again will be sending out your baseline data. PCCC reports, the template that Christine showed earlier, will be sent within the 2 weeks after your CHC has completed your PCCC collection. And then the PCCC and ECQM scores will be posted on the website, again on your site's dashboard in the dashboard tab. Start formulating your project team. So I know folks have been putting together members that would be helpful to have on the first initial calls. We do have some resources that can help you sort of figure out who would be the best person to bring along on this learning community. And that is located under the QI process and then forming the QI team on the website. Start brainstorming some potential QI areas. Again, under the assessment tab, we have that QI assessment, which will help weed out some areas where you all might think would be a good place. We encourage you to have both clinic champs as well as other folks on your teams to go ahead and take that assessment. Multiple folks on your team can take the assessment and you can review your answers together. And be sure to sign up for your TA session. So our next TA block of time slots is on October 7th from 8:30 to 10:10. They are 20-minute time slots, and we're going to send out the You Can Book Me link so that you can select a time slot that works for you. If October 7th, the morning of October 7th doesn't work for you, no worries at all. We can definitely accommodate other TA times. Just email us and we can find a time that works. Next slide, please. We're going to have a quick feedback survey. It's through Zoom, so it will pop up in your web browser immediately after the session. It takes like 1 minute to complete. Just wanted to see how you all felt about the session today. If there anything if there are any things that we can do to improve in the future, or just any thoughts that you had about the session, please do take our feedback survey. It would mean the world to us. And then again, a reminder for our next session on October 21st, 8:30 Pacific time. We are going to be hearing from Deanna Carvajal and Rachel Logan, two incredible presenters on health equity and racial justice. This would be a session that would be great for all folks on your team, but we definitely want to have anyone on the clinical team and any leadership positions that can make it to this would be incredible to have. It will be a really excellent presentation. We're looking forward to having you all on that call. Next slide, please. Oh, thanks, Seren. All right. And that is the end of our first learning session. Thank you all so much for coming today. Again, we'll see you on October 21st at 8:30 Pacific time. In the meantime, we'll have some contact via TA sessions, but feel free if you have any questions or you want to touch base with us. Our emails are listed here. You can direct messages to Sonia and I about any project work. If you have any questions about contracting or invoicing, Becky Kriz will be the person to reach out to there, and her email is also listed. Any last minute questions, please feel free to come off mute. And if we don't hear anything, we'll see you soon. Thanks, everybody.